Hello and good evening for everybody, and welcome to this edition of Circulate. My name is Omar Al-Haj. I'm a cardiologist here in City Hospital Mediclinic in Dubai, and today I will be chairing this session. I hope you find it exciting and interesting and interactive. We have two speakers for you tonight, and following their talks, we will be having a question and answer session at the end. The topics are, I hope you find them very interesting and educating as well. As you know, for a long time, we have been striving to find the perfect anticoagulant. We've been trying to balance the risk with the benefits and the efficacy, and today we will be discussing all these challenges. And if you have any questions, please don't shy away. We will be happy, and the speakers will be happy to answer them for you. So before we take too much time, I would like to introduce my friend, Dr. Brajesh Mittal, who is a cardiologist here in Dubai, and he will be talking to you about different populations of people who need anticoagulation, and different anticoagulants that can be used in these different subsets of people. Dr. Brajesh, you can start.
Thank you. Thank you, Omar. It's been a pleasure to have you as a chairperson, and also my co-speaker, Dr. Ajman. Good evening. And so it's always a pleasure to meet up with the colleagues, to learn from each other, and also the worthy audience whom we are not able to see, but they are all our colleagues, and they are all equally qualified and competent, but we all keep revising within ourselves the different concepts, and the established concepts we should go through all over again, so that we do not forget the main ideas. So my talk is on the special population for the I hope it's well visible to all of you. So difficult to treat patients or special scenarios of utility and applicability of the NOACs. So in a nutshell, there are two basic classes of indications for NOACs, non-valvular AF, venous thromboembolism. This is all what we know. And except these two scenarios where NOACs are not yet indicated, moderate to severe mitral stenosis and prosthetic mechanical valve, where we still do not have sufficient data, and warfarin remains the supremo in these situations. So what are the difficult to treat situations? The group which is elderly, above 75 or even above 80, the patients with high bleeding risk or pre-existing bleeding or GI bleeds, risk of GI bleeds. The third group is patients with renal dysfunction, and the fourth group is patients who are undergoing PCI and ACS and also requiring NOAC. Just please give me 1 second. I need to hide the panel. Yes. So what are the randomized trials of anticoagulant therapies for NBAF? So as early as in 80s and 90s, it was clearly shown that warfarin was superior as compared to aspirin or any other thienopyridine, or as compared to placebo for the prevention of stroke in atrial fibrillation patients. But then there was a long hiatus. We only were having warfarin, and we were using warfarin only. Then the trials started coming for the newer anticoagulations, like dabigatran versus warfarin, a very famous RELY trial. Then Rocket AF trial with rivaroxaban. Simultaneously almost came the apixaban versus warfarin trial. and then the latest one was the edoxaban versus warfarin. So within those 5-6 years, we saw four agents emerging and proving themselves to be superior as compared to warfarin. So there are currently 4 NOACs which have been studied versus warfarin for stroke prevention in atrial fibrillation. So classically, warfarin is the VKA or vitamin K antagonist. Dabigatran is direct thrombin inhibitor, while the other 3 are, they all contain this XA-BAN. So XA-BAN means XA inhibitor. So they are all factor 10 inhibitor, rivaroxaban, apixaban, and edoxaban. The first group of patient, which is of some concern and we need some care, is about the elderly group. So how should we apply? What are the NOACs which have been proven to be superior and better? So how safe are they? And we all know that even if age is not a bar, even if patient is quite elderly, if the patient is suffering from AF and has high CHA2DS2-VASc score, the stroke prevention is a necessity and NOACs are the essential part of the treatment. So safety and efficacy comparisons of NOACs with vitamin K antagonist in patients with atrial fibrillation were done with different agents, rivaroxaban, dabigatran, and dabigatran a smaller dose, dabigatran higher dose, apixaban. The primary efficacy outcome, apixaban was associated with lesser stroke and systemic embolism events with increasing age, which you will see a little bit here. But in general, all of these therapies did work without doubt. However, the major difference was seen in the rate of major bleeding. So obviously, apixaban was safer and reduced the risk of major bleeding with advancing age. If you see the middle line here, the patients who with apixaban, it was better. The patients with rivaroxaban or dabigatran more than 150 milligram twice a day, these were the patients where warfarin was superior in terms of major bleeding. So though the efficacy and safety could be there, efficacy and primary efficacy outcome was seen with almost every agent, but it was a bit better with apixaban and dabigatran higher dose. But obviously the clear difference was in the rate of bleeding. The solid line here represents the primary outcome of systemic embolism and strokes, and the broken line shows the risk of bleeding. So apixaban, then rivaroxaban, then dabigatran 150, then dabigatran 110. So all of these showed in the solid line is the advantage of primary efficacy. But when it comes to bleeding, clearly rivaroxaban showed more bleeding. Dabigatran 150 was also very close to the middle line. So the safest agent was either dabigatran 110 twice a day and even apixaban being better, favoring over the other agents. When the age groups were broken into 3 different categories, more than 75, 65 to 75, less than 65. So again, you will see in more than 75, rivaroxaban was, hazard ratio was higher for rivaroxaban for major bleeding, and dabigatran 150 milligram was also, it was higher, while in the case of apixaban, in all patients, whether above 75, 6, or below 65 or between 65 to 74, all these patients showed a superiority for the major bleeding safety. So apixaban therapy in elderly patients versus warfarin in the Aristotle trial. So the primary efficacy outcome you will see here in patients with elderly age group, this medication was superior, clearly superior, and in different subgroups, the apixaban was associated with lower rates of stroke and systemic embolism and lower risk of major bleeding versus warfarin in the elderly group of patients. So clearly, apixaban was better. So overview of NOAC dosing recommendation in NVAF was then like this, that apixaban recommended dose is 5 milligram twice a day. 2.5 milligram twice a day is indicated if any of the 2 criteria, either the age is very high, more than 80, body weight is less than 60, and creatinine is more than 1.5. Dabigatran also a smaller dose with more than 80, but you don't have to have 2 out of 3 criteria. If any one of these criteria, then the patient will enter into the group of lower dose. The rivaroxaban dose reduction criteria was based upon the moderate to severe renal impairment. So with advancing age, over 80 years of age people, the stroke versus systemic embolism in the apixaban group, it was superior. The major bleeding was lesser, and intracranial hemorrhage were also lesser. Besides the randomized trial, it was also observed in the Aristophanes, which was the real-world evidence, stroke and systemic embolism in NOAC versus warfarin in the elderly. So here you will see in the apixaban versus warfarin in the higher age group, more than 75 years of age, the efficacy was without doubt superior to warfarin, but at the same time, the major bleeding was also lesser as compared to the other agents like dabigatran and rivaroxaban. So it was repeatedly shown either in the randomized trial or in the real-world data. So in the elderly population, the expert recommendation more than 75 years of age is the apixaban 5 mg twice daily being the first drug of choice, while second choice goes to dabigatran 110 twice a day, rivaroxaban 20, edoxaban 60 mg respectively once a day. So discussion point is, do all NOACs exhibit similar outcome in the prevention of primary stroke? So bleeding part, we have already concluded that in elderly, bleeding is lesser with the apixaban as compared to any other NOAC. Then comes in the frail elderly patients, and this was the insight from the Aristophanes study. So here you will see apixaban versus warfarin, dabigatran, rivaroxaban versus warfarin. So stroke and ischemic events were clearly superior, and major bleeding were clearly less in the Aristophane trial. So though there were some limitations because this was a meta-analysis and there was no head-to-head comparison between the trials. So we cannot say very firmly, but these clearly indicated that apixaban was safer and superior in the action. In the FOTA classification, fit for the aged classification, which labels medications regarding their safety, efficacy, and age appropriateness for the treatment of a given disease with one of the four classes: indispensable, beneficial, questionable, and avoid. So proposed FOTA class as an anticoagulant for the NOACs is A for apixaban, while rest all fall into the category B. So A means the superior and the indispensable. The second part of the presentation is GI bleeding with NOAC, safety, which NOAC is better and how should it be used. So can NOAC be a safer option versus warfarin with respect to GI bleeding in elderly patients with atrial fibrillation? So first of all, why there is more chance of GI bleed with the NOAC? So one reason is the systemic anticoagulant effect. There is generalized bleeding tendency because we are giving a blood thinner. Then there could be incomplete absorption, topical anticoagulant effect. Then there could be direct causative effect, tartaric acid and dabigatran, which causes injury to the mucosa. And then there is inhibition of mucosal healing. So these are the various mechanisms by which the NOACs can cause GI bleed. Rates of major GI bleeding from the pivotal NOAC trials, it was astounding to see that apixaban had the major GI bleed incidence 0.76% per year as compared to dabigatran 150, 1.85% per year, and rivaroxaban 20 mg at the highest level 2% per year. So rate of GI bleed was clearly less in apixaban group. Dabigatran 110 mg does not increase GI bleeding versus warfarin. So only safer agent could be dabigatran 110, but in the given NOACs at the standard doses, it was the apixaban. So in the ESC guidelines, patients at high risk of GI bleeding in a vitamin K antagonist warfarin or another NOAC preparation should be preferred over dabigatran 150, rivaroxaban or edoxaban. The sentence is slightly twisted. So it clearly means that either you use apixaban or you use dabigatran 110 twice a day. Avoid these agents, 2A or B. So the classification level was class 2A and evidence being B. Again, in the Aristophanes study, the GI bleeding was when apixaban versus dabigatran were compared, the GI bleeding was in favor of apixaban, lesser bleeds. And when apixaban was compared with rivaroxaban, it was even more profound, the lesser bleeding with the apixaban as compared to rivaroxaban. It was not a head-to-head comparison, but it was a pooling of the data, and derivation was made as per the available data rather than being a direct head-to-head data. So safety of NOAC with regard to major GI bleeding, and there was a network meta-analysis. So probability of being the safest option with regards to major GI bleeding, the safest agent was apixaban as per the probability, and the least safe was rivaroxaban. Then comes the edoxaban was close but not equal in the probability of being safe. So apixaban and edoxaban had the most favorable major GI bleeding safety profile, while rivaroxaban and dabigatran were the least safe. So, and then outcome of different NOACs with respect to GI bleeding, large population-based study. So it shows that dabigatran versus rivaroxaban comparison, apixaban versus dabigatran, apixaban versus rivaroxaban. So it showed that for GI safety profile, least favorable was rivaroxaban, most favorable was apixaban. Apixaban had 75% and 82% lower risk of association with GI bleeding in the elderly versus dabigatran and rivaroxaban respectively. And even in the very elderly, above 75 years, apixaban had 55 and 61% lower risk of association with GI bleeding as compared to dabigatran and rivaroxaban respectively. So most favorable agent was apixaban. Higher risk of GI bleeding, if it is there, the available data suggests that first choice of the agent should be first patient with a high risk of GI bleeding, apixaban 5 mg twice daily, or dabigatran 110 mg twice daily must be used, and then the other agents come as a second choice. Major bleeding followed by death within 30 days in Aristotle trial. There was 50% relative risk reduction with apixaban for major bleed as compared to warfarin. The apixaban compared with warfarin was associated with fewer intracranial hemorrhage, less adverse consequences following extracranial hemorrhage, and 50% reduction in fatal consequences at 30 days in cases of major hemorrhage. So that was a very, very important finding because the initial comparison was warfarin, which was a pre-existing available comparator, and apixaban fared much, much better in terms of major bleeding related deaths. So bleeds associated with oral anticoagulants, apixaban compared with warfarin was associated with fewer intracranial hemorrhage, less adverse consequences, and lesser bleeds. Most of the bleeding events associated with oral anticoagulants can be managed conservatively by omitting few doses of oral anticoagulants. Bleeding management should be based on hemodynamic instability, source of bleeding, and degree of blood loss. And antidotes are important for life-threatening bleeding, but they also have been associated with mortality risk. So why these sentences are important? That it is difficult to deal with the bleeding, so better avoid bleeding, better use the agents which are safer for the prevention of bleeding. Apixaban was associated with the lower rate of major bleeding compared with dabigatran also and rivaroxaban also. So based upon this, 2017 expert consensus recommendation was that in patients with age more than 75 years, apixaban 5 mg twice a day being the first choice, and patients with high risk of GI bleeding, apixaban 5 mg twice a day should be the first choice. And also in the 2018 CHEST guideline and expert panel report, patients with prior unprovoked bleeding, warfarin-associated bleeding, or at high risk of bleeding, you have to use an agent which is safer, like apixaban, or closer to it, next closest is the edoxaban, or a lower dose of dabigatran 110 mg. Patients with prior GI bleeding, apixaban or dabigatran 110 mg may be preferable, as they are the only NOAC associated without an increased risk of GI bleeding compared with warfarin. 2016 guidelines, also 2020 guidelines also showed that patients with AF and GI disorder, consideration should be made for drugs such as apixaban, which are not associated with an excess of GI bleeding compared with warfarin. So based upon the based upon the randomized trial with warfarin, plus data, plus real life data, plus meta-analysis compared to other agents, apixaban was the safest in terms of bleeding reduction and in the elderly patients. Now, the third part of the specific situation, or the situation where we have to be more careful, is the use of NOAC in the chronic kidney disease patients. So NOACs in renal failure is a very unique agent. The dose, in general, the dose adjustment of NOACs is based on renal excretion. So here you will see, as the GFR declines, the dose keeps on changing for dabigatran, and below 30, it is not indicated. For rivaroxaban below 15, or in patients with dialysis, it is not indicated. While the dose reduction starts from 50 ml, edoxaban dose reduction starts at 50 ml GFR, and at dialysis patient, not indicated. In apixaban group, until 15 ml, it can be given, and the dose reduction criteria is based upon not just the renal function, it is based on 2 out of 3, age more than 80, weight less than 60, and creatinine more than 1.5. So what does it mean that if somebody's creatinine is high and GFR is falling into this group, but patient is 76 years old and weight is 70 kg, then you can give the full dose. You don't need to reduce the dose. So even dose reduction is not necessary unless you have 2 out of the 3 criteria which are mentioned here: serum creatinine more than 1.5, age more than 80, body weight less than 60. In the further update, it was shown that apixaban can be given even in the dialysis patients based upon the same criteria of dose reduction. So in anticoagulation regimen balancing risks and benefit, recommendations for selecting an anticoagulant regimen balancing risk and benefits. So class 2B, for patients with AF who have a high CHA2DS2-VASc score and who have end-stage chronic kidney disease or are on dialysis, it might be reasonable to prescribe either warfarin to maintain INR 2 to 3 or apixaban. This is the only NOAC which is indicated or allowed in patients with very low creatinine clearance or patients being on dialysis. Similarly, anticoagulants which are licensed for the treatment of DVT and or P are all the 4 agents, while apixaban and rivaroxaban can be started on day 1 without prior treatment for the low molecular weight heparins. So for VT treatment, all NOACs were non-inferior to low molecular weight heparin and warfarin for reducing the risk of VT-related death with varied bleeding profiles. However, in the amplified trial, apixaban showed comparable efficacy and safety, significantly lower major bleeding risk versus low molecular weight heparin or warfarin. So the safety was proven even in the DVT-PE patients by the amplified trial for apixaban. So apixaban versus warfarin for VTE in clinical practice, recurrent VT in bleeding outcomes in Vicar 2018 analysis. So recurrent VT, major bleeding, all favored apixaban as compared to warfarin. So friends, I presented you 3 specific scenarios: elderly patients, chronic kidney disease patients, patients with either pre-existing bleeding, high risk of bleeding, and GI bleeds. In all these patients, it has been shown based upon the trials and also included in the guidelines that apixaban is a safer option as compared to other NOACs. The 4th specific group is post-PCI patients or acute coronary syndrome patients. These are the patients who, if they have atrial fibrillation and they may need a therapy with the NOAC as a triple therapy, as a dual therapy, this particular discussion will be carried forward by my co-speaker, Dr. Ajmal. So thank you so much. And we'll take the questions in the end of the 2 sessions, 2 lectures.
Thank you very much, Dr. Mittal. That was very informative and very comprehensive. Thank you very much. We will proceed to the next talk. Dr. Haider Arjman from American Hospital. He's a consultant interventional cardiologist, and he will talk to us about current updates and some scenarios in the management of anticoagulation. Dr. Haider.
Okay, well, good evening again. Can you guys hear me?
Yeah.
Excellent. So I guess you couldn't hear me, some technical issues, but Dr. Omar, thank you. Dr. Brajesh, glad to hear from you and see you. That was an excellent review. I'm going to start with a case, which is a 45-year-old gentleman with history of smoking, dyslipidemia, hypertension, and paroxysmal atrial fibrillation. And you see that his CHA2DS2-VASc score on presentation is 1, and Has-Bled score is 1 due to some degenerative joint disease. He was taking non-steroidal anti-inflammatory medication, and that's the reason why his Has-Bled score is 1. He presented with chest pain for several hours. His ECG showed anterior biphasic T waves. Lab data showed elevated troponin. In the emergency room, he was given antiplatelet therapy and intravenous heparin. And here is initial pictures of the right coronary artery, which has no significant disease. And this is a video picture of left coronary system. It's a good thing that we have interventional cardiologists with us. Dr. Mittal can definitely help us with this case. And as you can see that there is some degree of left main disease and also severe proximal LAD disease. So this was a patient, obviously, that we're going to discuss concomitant coronary artery disease and also paroxysmal atrial fibrillation. I'll go through some data and I'll get back to case again. So the scope of what we're talking about is concomitant atrial fibrillation, coronary artery disease, and acute coronary syndrome. So obviously we know atrial fibrillation, as Dr. Brajesh mentioned, is a very common process. Happens, depending on the age group that you look at, in 20, 30, 40% of the population if they are more than 70 years of age. And the same coronary artery disease is a very common disease process, and not infrequently we get patient population who both have atrial fibrillation and coronary artery disease, and of course, given two disease with significant adverse outcome, this patient become a high-risk group, and addressing their antithrombotic antiplatelet therapy becomes a vital part of their care. If you look at whatever data you look at, you see a significant number of patients who have concomitant atrial fibrillation and coronary artery disease. And depending on data you look at, this ranges from anywhere from 20 to 45%. And of course, the older the patients are, the higher the incidence of atrial fibrillation and the higher the incidence of coronary artery disease. At least about 1 in 10 patients that we treat with acute coronary syndrome or PCI have concomitant atrial fibrillation. And again, depending on the patient population, the percentage may be higher. Of course, needless to say, those patients who present with acute coronary syndrome or patients we do elective PCI, they are treated with dual antiplatelet therapy. Patients who have atrial fibrillation, they are treated with anticoagulation therapy, either vitamin K antagonist or NOAC. Hopefully, nowadays, the practice guidelines recommend NOAC as first-line agent. I don't know the last time I started the patient on warfarin. So, of course, when patients have both conditions, then you are left how to treat these patients. Do you give them triple therapy, aspirin, a PTY12 inhibitor, and an oral anticoagulant, or dual therapy? Dual therapy usually includes an anticoagulant and single antiplatelet agent. The initial data on dual compared to triple therapy goes back to 10 years from both trials that randomized patients to patients triple therapy, aspirin, P2Y12 inhibitor, and warfarin, or dual therapy. And you see, even using warfarin, which obviously we just saw is associated with higher risk of bleeding, using warfarin but on dual therapy had lower risk of bleeding compared to triple therapy. So this was proof of concept that dual therapy with an anticoagulant and antiplatelet agent, P2Y12 inhibitor, has much lower risk of bleeding compared to patients who are treated with triple therapy. And if you look at individual endpoints of death, myocardial infarction, target vessel revascularization, any clinical endpoint that you look at was favored by dual therapy compared to triple therapy. Similarly, going back to 2015, this is data from German group, Albert Schomi group, that patients who were randomized in ICER triple trial, again, triple therapy compared to dual therapy, there was no significant improvement in those patients who were randomized to shorter duration of P2Y12 inhibitor. So I think neither dual therapy nor shorter duration was a factor in improving outcome. So now if you look at the patients with ACS or coronary artery disease and AF, what is the data, available data in this group of patients? We have several randomized clinical trials. Obviously, for the sake of time, I will not go in depth in all this trial, but needless to say, all the NOACs have data regarding combining anticoagulation with P2Y12 inhibitor, dual versus triple therapy. But as they say, devil is in the details. They all randomize patients, but depending on what patient population and specifically how they were randomized. These trials are Pioneer AF, Redual, and Trust and Augustus trial. And this is an overview of those trials. And as you can see, they range from 1,500 patients in Entrust to 4,600 patients in Augustus trial. So you see the Augustus trial was the largest randomized trial looking at this. And more importantly, this was a 2x2 randomized trial. So it did not look at just two groups of patients rather than four groups of patients. So we have data to look at in each subgroup. Additionally, it included patients who were not only treated with PCI, but those acute coronary syndrome that were treated with medical therapy, and also patients who had prior ischemic cerebral event. But a summary of this, both Pioneer and Redo showed that there was reduced risk of bleeding in dual therapy. So rivaroxaban with a P2Y12 inhibitor compared to triple therapy. And same thing for Entrust AF PCI showed that this was non-inferior compared to triple therapy. One thing which is different in Augustus trial and episciban in patients with ACS, PCI, and CAD, that, as I mentioned, the mode of the trial, how they were randomized is different. It included patients with medically treated patients, and also it included patients who had prior history of a stroke or TIA, anemia, and GI bleeding that Dr. Burgess reviewed with us. So some in-depth analysis of the Augustus trial, randomized 2x2 factorial design, patient received apixaban 5 mg BID in selected patients, including patients with end-stage renal disease. Apixaban was 2.5 mg, or those patients who were elderly or had concomitant age or chronic kidney disease factors. The inclusion criteria included atrial fibrillation, ACS or PCI in the prior 14 days, and the choice of P2Y12 was either ticagrelor or prasugrel or clopidogrel. Most of it, as I will show you, was clopidogrel, but there were some patients who were treated with more potent P2Y12 inhibitor. And the exclusion criteria, it's really the routine criteria that is used in this trial. Patients who had severe renal insufficiency, even though apixaban does have their renal insufficiency patients, intracranial hemorrhage, or if they were not able to take the medication for any active contraindications. The primary and secondary outcome included, most importantly, major bleeding or clinically relevant non-major bleeding. And of course, those bleeding are important because as any cardiologist, especially interventional cardiologists doing procedures, we know that we do a procedure, goes well, and the bleeding issues result in prolonged hospitalization, sometimes result in discontinuation of antiplatelet therapy, which itself can lead to a stent thrombosis, and of course, major adverse cardiac event. So bleeding events are very critical in this group of patients. Secondary outcomes were all-cause death or hospitalization, or all-cause death and ischemic event, including a stroke or a stent thrombosis that I just mentioned, or urgent revascularization. This is a wide-world global trial, randomized over 4,600 patients, and I said it was the largest NOAC dual therapy comparison trial in patients with AF, CAD, PCI, and AS as compared to other 3 trials. Specifically, the CHA2DS2-VASc score, as you can see, the was almost 4, mean CHA2DS2-VASc score, and Hasbulla score was 3. So you can see that these were high-risk patient population. 90%, 92% of patients received clopidogrel, but about 6 to 7% of patients received ticagrelor as the PTY12 inhibitor. And I'm going to come back to this point as a discussion with Dr. Brajesh. I wonder what he does in his clinical practice when he treats patients with PCI and P2Y12 inhibitor and NOAC. But this mostly consisted of clopidogrel as a P2Y12 inhibitor. This is an overall primary endpoint. You see that in patients who received vitamin K antagonist compared to, so triple therapy compared to apixaban, 31% risk reduction compared to those patients who received vitamin K or warfarin. So significant reduction in major bleeding or clinically relevant non-major bleeding. Aspirin use, of course, significantly increased the risk of bleeding in these patients. You see, if they were treated with dual therapy, regardless of whether they had warfarin or NOAC or apixaban, aspirin use significantly increased the risk of bleeding. So this further proves the concept of dual therapy, which was shown 10 years earlier in Wo's trial, that was dual therapy was better than triple therapy. Now, of course, Augustus takes the field even further, that compared to warfarin, 30% relative risk reduction was achieved in patients who were treated with dual therapy compared to warfarin. Now this looks at all the subgroup of those patients, P2Y12 plus apixaban, P2Y12 plus vitamin K antagonist, P2Y12 triple therapy, vitamin K triple therapy. And as you can see, the combination of P2Y12 and apixaban was associated with low risk of cumulative cardiovascular events compared to any of the other items, especially when it included vitamin K antagonists. And it did not really matter whether the patients with acute coronary syndrome treated with PCI or medical therapy. And that's very important, because if you look at all the ACS patients, when they come to hospital, if you look at all the ACS trials, about 60% of them are treated with PCI. About 20–30% of the patients, because of diffuse disease, because of lack of culprit vessel, are treated with medical therapy. So it's very important how we treat those patients with ACS and concomitant atrial fibrillation. And of course, about 5 to 10% of patients with ACS may be treated with surgical revascularization. But those subgroup of patients with acute coronary syndrome who come to hospital are not treated with revascularization and are treated with medical therapy are included in Augustus treated with apixaban as compared to other NOAC trial looking at concomitant PCI and AF. As I mentioned, these patients in this trial included patients with prior stroke. And as you can see, the dual therapy compared to vitamin K-based regimen, apixaban was associated with significant reduction in stroke as well. So the two very items that are very important in acute coronary syndrome is avoidance of bleeding. So this falls into bleeding avoidance strategies, and of course, avoiding of major ischemic event, including stroke. And apixaban in Augustus achieved both of those goals. These are the key points that I went through. 31% reduction of major bleeding or clinically relevant non-major bleeding, 70% reduction in death or hospitalization, similar rate of death and ischemic events, and of course, significant overall improvement. Coming back to the clinical case, as you saw when I showed you, this patient's CHA2DS2-VASc score was 1, and Has-Bled score was 1. Of course, assessing this patient's bleeding score is 2 because patients now is going to be on a concomitant anticoagulation because his CHA2DS2-VASc score is now 2. So higher CHA2DS2-VASc score, higher Has-Bled score. This is how the case went. Because the patient had left main disease, we actually did an FFR of his left main, make sure that his left main is not significant. And the left main FFR evaluation was not significant. So we were left with addressing his severe proximal disease in the left anterior descending coronary artery, which, as you can see, we did angioplasty and stenting, followed by IVUS optimization, and we got a very good result in this patient. So this is how the patient got discharged home. Patient had successful PCI of LAD via left radial axis. Obviously, that's another, I mentioned bleeding avoiding strategies, doing dual therapy, apixaban and a P2Y12 inhibitor is one of the bleeding avoiding strategies. Using radial axis in this patients is in bleeding avoiding strategies. The patient was discharged home on apixaban on ticagrelor rather than clopidogrel, and I'm going to come back to this point for our discussion with Dr. Omar and Dr. Brajesh. On high intensive statin therapy, atorvastatin, Lipitor 80 milligram daily, Ramipril 2.5 milligram daily, and bisoprolol 2.5 milligram daily. I'm going to come back to this slide when we get to our team discussion. So going back, 2x2 factorial design is a important point separating this from other clinical trial. This is all the clinical trial put together. How we would decide on what agent to use, it depends on what patients will enroll. So yes, there is an indication to give NOAC in patients who are treated with PCI, but a specific patient population, I think is important to look at a specific clinical trial and read between the lines what patients were enrolled in a specific trial. While you cannot compare across trial, this is an overview of all the trials. And as you see, in every trial, it favors dual therapy using NOAC, but while this is not randomized head-to-head, but over the unity line, it's more favoring apixaban compared to other agents. So in summary, Augustus provides us with evidence to support apixaban plus P2Y12 inhibitor as compared to vitamin K antagonists, and also it supports the use of dual therapy versus triple therapy. I'm going to stop here and go back to these slides just as a discussion point. I'm going to end here. Thank you very much. Let's see, do we have Dr. Umar?
Yeah, thank you. Thank you very much, Dr. Haider. That is very interesting and very informative as well. It's obviously one of the difficult situations that we come across every day. Now, I think we will give the priority for our audience if they have any questions. I'm sure they will be. I don't know who has, maybe Hazim has the questions, or Rania, somebody has contact with the audience, received any questions? Hello?
If there is no question, while you're reviewing the question, I actually would like to look at the last case that I reviewed. Dr. Burjesh, what is your practice when you do dual therapy in ACS, PCI, and CAD patients? And that's the first. And the second, when it comes to combining apixaban with P2Y12 inhibitor, are you are sticking to the 90% rule of using clopidogrel, or do you use other P2Y12 inhibitors? So two-phase questions for our audience while Dr. Omar is getting more questions through WhatsApp.
Okay, so both are very relevant and practical questions. I will answer the second question first. That as we understand, if we have to reduce the risk of bleeding, clopidogrel could be a much safer option when you combine with an NOAC. And this is what was done in the guidelines also. The guidelines have not clearly specified that which P2Y12 to be used. But if you go back a bit 5 years earlier, the guidelines were clearly indicating that if you are giving an oral anticoagulation, then give clopidogrel only. Now they have removed that part and they have allowed prasugrel and ticagrelor. So I would be still hesitant if I'm giving an NOAC to use anything other than clopidogrel. This is my first answer. The second thing is, although we have a clear knowledge that dual therapy is quite sufficient, but we need to have a spectrum. We need to understand the spectrum of high thrombotic risk versus high bleeding risk. And based upon that, our strategy should follow. If clearly there is high bleeding risk, then right from the beginning, we'll be on a dual therapy. Suppose you would have done left main PCI also for this patient. I might have gone for the triple therapy for at least a few weeks or maybe a month. But here, because left main was spared and not needed to be done, we could start our initial strategy as a dual therapy. But still, if you see the Augustus trial, they randomized the patients after 2 weeks. So first 2 weeks, every patient received triple therapy. This was in the trial. So still, when we say dual therapy, it means at least in the initial phase, if the bleeding risk is not high, at least for 2 weeks, and that's what the guideline also says, that standard care is to give triple therapy for a few weeks. Then you decide whether you want to give more triple therapy, how soon you want to terminate triple therapy, and how soon you want to terminate dual therapy, 6 months or 1 year. So this is how, it is still a tailored thing. It is not a one thing fits everybody.
That was awesome. That was great. So I fully agree with 100% of what you said. So the data does allow for 1 week, 1 month, depending on the bleeding and thrombotic risk. I think for this, we could talk several hours about the spectrum of the patients who fall in this category, and also the logistic of the patients. So I have, most of this trial, including the Augustus and Pioneer AF, included patients with ticagrelor. Obviously, if you go second level and look at the ticagrelor and clopidogrel data, most of the major bleeding risks were the same. And also, this particular patient was an international patient that I would not be seeing afterward. I literally saw in next day, and patient was on the plane. So it was a definitive therapy before leaving it to someone rather than triple therapy. So sometimes logistic factors in Dubai come into play as well.
Yes, absolutely. Yes, any other?
That's great discussion. I think the one thing that our interventional colleagues should always assess is the bleeding risk. And as Dr. Mittal said, it's a balance between thrombotic risk and bleeding risk. I think you have to put your patient into one of those two. Sometimes he probably be neither the patient, and then in that case, it will probably be easier to go for the dual therapy. Patients who have high bleeding risk, of course, are the problem, and I think always better to discuss with the patients as well, and to get them to understand your choice, or is what is it based on, so that they know the options, and they know why we're choosing one strategy over the other. I haven't received any questions yet. Sorry, maybe there might be.
Dr. Mittal, you briefly mentioned VTE. I just saw a patient 2 weeks ago in my clinic who was actually hospitalized in ICU, came with chest pain and shortness of breath, had significantly elevated D-dimer, so had elevated troponin, had a chest CTA which showed pulmonary embolism, although not proximal, distal pulmonary embolism. So did get diagnosed with PE, also had elevated troponin, known coronary disease, and prior CABG. So I capped him, and of the 3 grafts, 2 were occluded. He had a patent graft from SVG to RCA, no graft to LAD and CERC, with significant LAD disease and significant left circumflex disease. How should we approach this patient? So PE, acute coronary syndrome, non-ST elevation MI, elderly woman.
Interesting. So my first question is to make sure that this troponin was not because of ACS. Maybe it was only because of PE, acute PE, because that can also cause troponin elevation, unless you had a clear change in the ECG, which was suggestive of clear new
changes. Yeah, we did have
new
STD changes, and she came with chest pain, plus shortness of breath.
Chest pain, raised troponin.
Could be because of PE, absolutely.
All because even the some changes in the ECG. So we aren't sure that this was really an ACS. If you ask me personally, I would rather go for a medically treated ACS in that situation at that point of time, because patient was still, I would say, a low risk ACS, hemodynamically stable. It's generally hard to believe that at the same time patient had both the acute pulmonary embolism as well as acute coronary syndrome. It can happen, but it happened to this patient maybe. So I would be a little more conservative and a post-CABG patient with the PE and medically treated. And now we know that
more information. 6-hour travel from North Africa.
Yeah. So again, it was a clear provocation of the PE, clearly. Now, interesting here to discuss is
not the elevated troponin as an acute coronary syndrome, or treat medically.
So treat medically. Now, interestingly, when you go back to your slides, there was a very clear data which was showing that the best effect of or most advantage of apixaban was in the group who was medically treated. Not in those groups which were those who were with stent or acute coronary syndrome. So medical treatment of ACS, especially in a multi-vessel disease and in a patient who had cabbage before, it could have been a good option. Maybe I would have gone for dual therapy, considering there is also apixaban and maybe some clopidogrel, and that's it for that timing. This could have been my approach, but that all depends on that spot. What do you decide and how do you do? Now, my second question to you is then, after doing the cath, did you find anything which was suggestive of acute occlusion or anything which was suggestive of an acute coronary syndrome?
So obviously that's a great question, and geographically, obviously we can go back to the imaging and what imaging criteria for a potential ACS lesion. But yes, so we CAD the patients, and in addition to patency of SVG to RCA, she had a 90% proximal to mid LAD disease and 99.9% hazy thrombotic left circumflex disease.
So it was thrombotic, acute occlusion. Yes. Then it is Word's publication that patient had simultaneous left and right arteries of occlusion, systemic as well as coronary, pulmonary as well as coronary. This is I don't think it's a very common scenario. It's probably one of the rare scenarios where you have both. And then
rare scenario, absolutely.
Yes. So obviously, then what was the age of the patient?
72.
And has bled?
Has bled 3. No other, fairly good. No other, even not even NSAID taking at 73 years of age. Obviously,
I think you would have gone for dual therapy instead of triple therapy right from the beginning.
And that's what we did actually as well.
Yes, that's true. Great. It was a very different case. I never heard of such a case. We had one case which was an elderly lady, and she was 85 when she presented with acute intravenous MI, and we treated her with the primary PCI. And during hospitalization, in spite of being on aspirin and clopidogrel, she developed DVT on the proximal vein. So then our strategy changed.
Yeah.
Yes.
It became concomitant. It wasn't concomitant. It became concomitant.
Yes.
Very good.
Thank you.
I have a couple of questions here. The first question, which I think is being asked by a couple of people. They're actually asking the same question to people. I think the question is to you, Dr. Haider, is why discharge the patient without aspirin in the first 4 weeks and then omit aspirin and continue ticagrelor and apixaban? Why did you go for dual therapy from the beginning rather than giving aspirin as well?
I think that's what Dr. Brejish and I were discussing. That's what the guideline says, and that's what the data says as well. The main reason for that, patient was going beyond my care. So patient was leaving the country, and it would have to be left to somebody else to change from triple therapy to dual therapy. Patient's ischemic risk, I thought, was low, so I was very comfortable treating patient with dual therapy rather than triple therapy from the beginning. That's why I actually specifically put these patients as a case rather than making it simple, saying, well, we send the patient home on ticagrelor, on clopidogrel and apixaban. But the guidelines and the data says, depending on your spectrum of ischemic and bleeding risk, up to 1 month, 1 week, 2 weeks, or 1 month, you could do triple therapy.
Good. Okay. Another comment is that somebody wrote and said, regarding prescribing guidelines for NOACs in the Middle East, some publications reported that adherence to prescribing guidelines in the region is more In addition, some authors documented variable levels of reported adverse events. To what extent these two elements can be associated? I'm finding it difficult to understand exactly what is the comment here, or what's the question. But I mean, how do you feel? First of all, let us take these two things: prescribing guidelines or adherence to guidelines, and then adverse event reporting. Any insight into what is the situation in the Gulf region? I mean, I know that we're using more NOACs than warfarin, that's for sure. I know that there is still a little bit of under-prescribing for NOACs, particularly in atrial fibrillation. There is still hesitancy. There are people who are following the American guidelines, people are following the European guidelines, and that is very important when the CHA2DS2-VASc score is one in males and 2 in females. The Europeans recommend that you anticoagulate these people with AF, while in the Americans are giving it, I think, a class 2A. I haven't actually finished reading the new 2023 guidelines that have just come out from the US, but I don't think they would have changed very much. I think they were still sticking to class 1 in 2 for males, and CHA2DS2-VASc score of 3 in females. Prescribing of adverse events. Does any of you reported any adverse events related to NOACs in the past few years at all, other than the very well-known sort of expected, I should say, expected bleeding risk?
So if I can take a stab at the first comment that you commented on, I think, while I was presenting the NOACs, I mean, obviously we're here talking about apixaban, but NOACs in general, I don't actually, with the 2 exceptions that Dr. Mittal mentioned, mitral stenosis and mechanical valves, I think with those exceptions aside, I think there is plenty extensive data that NOACs are as good, superior to warfarin therapy. So there is regional variations. Even if you look at it in US, there is difference from state to state. But definitely first-line agent for treating patients with atrial fibrillation. I think the second question, I similar to you, I wasn't sure specifically what the question is as far as individual adverse event reporting by providers like us, or you mean globally as in the nation? I wasn't sure what that question lies.
No, people who prescribe anticoagulants like us. I mean, I personally haven't reported any adverse event because all what I see is just minor bleeding, to be honest with you. Major bleeding, unfortunately, when it happens, we don't get informed of it because the patient ends up either going to the neurosurgeon or to the gastroenterologist. But I'm sure they do happen. I haven't heard of a massive bleeding recently, luckily. I think these events are very rare. I mean, I don't know what your experience is regarding major life-threatening bleeding events.
Generally, for me, I would go with your experience. Fortunately, it is not much. Maybe we are missing out some people, but usually in our practice, even if patient goes at the acute event to somewhere else, later on, obviously that patient will come back and tell us that I had a bleeding episode and I went to the other doctor. So generally speaking, we didn't encounter the adverse reactions. Occasionally we notice some, but we don't report actually because patients are already in polypharmacy. If somebody says, I'm having nausea or something, we don't report all such events because we can't correlate very well. that it is because of this particular medication. So reporting is not perfect, that we will agree. And side effect, discontinuation, I have seen once or twice with the rivaroxaban with some weird feeling with for somebody, etc. But that was also not very clear. But that was the only thing which I have noted. But in general, it is quite fine. The only thing which we need to explain to the patient is compliance, because there are two types. Two medications are twice a day and two medicines are once a day. So then twice a day medication compliance has to be assured or ensured more clearly with the patient.
Okay, a couple of more questions. The first one is somebody is asking, what situations would you switch from one NOAC to the other? And are there any guidelines regarding changing from one NOAC to the other in certain situations?
Doctor?
That's actually a very good question. I mean, we have data on how to transition from warfarin, how to transition to enoxaparin. I don't know of any specific scientific document on how to transition from one NOAC to other NOACs. Just really looking at the half-life of how long this will last. You know, when I just have a patient who is on apixaban is going to have removal of a sigmoid colon. So we know the time frame of holding these medications, and that would be the most that you need to transition from one to other. But I'm not aware of any specific document. That's a good question.
Okay, and the last question that I have here is about specific antidotes for NOACs. Somebody said that edoximab is licensed, for example, in the UK as an antidote for dabigatran, and andexanet alpha reverses the bleeding effects or the effects of the factor 10 inhibitors, mostly apixaban and rivaroxaban, but it's not very clear whether it also works for edoxaban. The person who's asking is saying, would that be enough reason not to use edoxaban since we don't have an antidote for it? I mean, my answer to that was we were using these agents before the antidotes were created.
Yeah.
So
Yeah.
I don't know what guys.
Exactly.
How do you feel about edoxaban?
Exactly, I would have given the same answer what you have given. That antidotes were not there, and still you are using it, and still we are using it. And also, it is if you carefully go by the guidelines and use them judiciously, with the proper assessment of the patient's risk, and reduce the dose as per the guidelines, balance the dose correctly, the chances are very less. It is also shown that patients, which was in one of my slides, that patients who had a major bleed and got the antidote, and even though their bleeding was well controlled, even though they improved, but still their mortality was higher. So antidote themselves were somehow leading to more mortality in the future. This was also shown in the slide.
Mm-hmm.
So this may not be a sufficient reason not to use. This is what I would say.
And the availability of antidote across the globe is very, very different. And I can even tell you that in the US, the availability is varies significantly and depending on the insurance approval. So I think what Dr. Mittal said, proper detailed assessment at the beginning and then periodic, because these patients, they get older, they get more frail, they may start using other agents that increase the risk of bleeding, the renal function might get worse. So assessing those and adjusting the dose, I think on a global basis makes population basis makes more significant difference than those isolated patients that may need antidote.
Yeah, I think that's an important point. Thank you for mentioning that. I think monitoring these these patients, especially people who are on the cusp of especially renal function. You start somebody whose creatinine clearance is 55, and then you just sit there without checking it periodically. It might dip at any time, and then your dose might need to be readjusted. Somebody is asking about loading dose for NOACs. And if the patient was on Elclexane, do we have to load the patient, or you just start with the regular dose? I think the answer probably is just the usual dose. You don't load them.
Yeah, no loading dose. You just start because
they work very
That's
quickly,
right.
don't they?
Yes.
So
I
in
just
the
want to
case
go
of-
back to one question that has been asked before, which is switching between NOACs. May I just give you a scenario? I saw a patient who swears that he takes his anticoagulation religiously, and he had an embolic stroke. What would you do? I mean, he has not missed a single dose for months or for years, and despite that, he still had an embolic stroke. I mean, I always tell the patient that it reduces your risk, but it doesn't actually sort of
make it zero.
abase that
Yeah.
risk completely. It's a little bit unfortunate that that patient had this stroke. But what would you do in these situations? I mean, obviously, you have to do
please
something.
To please ourselves, we change the medication and believe that because of this medication, he got the stroke. But as you rightly said, the medications finally are not panacea. Whatever we use, whether we use statins and whether we use anticoagulants, they do not provide 0% risk. They reduce the risk significantly, but it's not 0% ever. Events will still happen. So we
So you will
change.
change
I
it,
changed
yeah,
from I changed from rivaroxaban to apixaban in one patient, just thinking that maybe rivaroxaban was not working for him. But that is all what we can do and nothing more. We may go for other therapies like ligation and the appendage therapy, all those occlusions. If we believe that this
left
is
atrial appendage closure device, yeah, that's what we did in a couple of patients actually.
Yeah.
But again, I mean, there is no clear evidence that would. Yeah.
I think on that particular scenario, obviously this again, we were talking about ischemic risk and bleeding risk. And when we talk about ischemic and bleeding risk, we're not just talking about atrial fibrillation. These patients are a lot elderly. They may have aortic arch atheroma. They may have carotid artery disease. So if we have them on apixaban or NOAC, and they may have a significant 99% carotid disease and not taking optimal intensive statin therapy, then in those patients who, obviously 2 points. One, they can still have, event can still happen regardless of what therapy you are on. Second, looking for other potential cause of ischemic stroke, including carotid disease, aortic atheromas, and so on, which might not necessarily be identified at the beginning, but as the patient age, we need to look for other causes.
Good point. Yeah, good point. That's a very good practical point. I mean, I'm run out of questions here, but if there are any other sort of issues that we haven't covered that anybody would like to raise, we can talk about it.
Or we can talk in the next Circulate. Many Circulates are happening. So, but overall it was good. We learned and we rehearsed and we recapitulated our all knowledge and discussed so many different points, because there is no final answer in medicine. So every time we discuss and we get to know something new and something different, like your case with PE and ACS together. So
Absolutely. Maybe I'll bring the angiogram for our next session.
Yes, good. Thank you.
Very good. Likewise, it was great to join you guys, Dr. Mittal. Good to see you again.
Thank you.
Dr. Ahmed, good to know
Thank
you.
Yeah, no, that's very enjoyable and very enlightening and educating. Thank you very much for your
Thank
efforts.
you.
And I also thank all the audience, everybody who has joined us in this evening. And I think we will say goodbye to everybody and thank you all very much.
Thank you. Good night.
Thank you. Right. Good night.
Thank you. Bye.